John. So the question I was asked was to address how to treat early relapsed follicular lymphoma, and I don't have a perfect answer for it, and I decided to approach it rather than giving an exact answer, just to review the data behind the topic, and I think ultimately we all make decisions based on what seems right at the time. So I learned a lot, almost everything I know about follicular lymphoma from John, and so not surprisingly, I have kind of the same approach. And the first thing I think it's important to realize is that follicular lymphoma is primarily a disease of excess morbidity rather than one of early mortality, and this is data from the Mayo Clinic with a validation set from France, essentially showing that patients with follicular lymphoma, newly diagnosed follicular lymphoma, that don't have an event within the first 12 months of life, whether that's they're selected for observation and then don't progress within 12 months, or they're treated immediately and don't progress within 12 months. These people have a survival that's essentially equivalent to the general population without lymphoma at all. That's why, as Jonathan Cohen mentioned earlier today, that's why we don't see overall survival benefits in follicular lymphoma trials. You'd have to make somebody live longer than somebody without cancer. Unfortunately, some people with follicular lymphoma do experience excess morbidity or excess mortality. And Carla Casula has shown this in multiple settings, essentially demonstrating that patients who experience disease progression within the first 2 years of frontline treatment with immunochemotherapy have a survival rate that's about 50% at 5 years, significantly worse than the rest of the patients. So it's these patients, theoretically, where we need to develop not just treatments that are better tolerated, but in particular treatments that are more effective. One of the first factors I think we have to address in people that experience early progression is the risk of transformation. It turns out that roughly 30 to 50% of patients that experience early transformation, depending on the study we look at, or experience early progression are likely due to transformation. Transformation seems to occur at a relatively low rate and then plateau after about a decade, but many of the transformations will occur early on. Interestingly, we're not great at predicting transformation other than to look at sort of basically available clinical risk factors, but things like gene or mutational profiling may not predict transformation as well as it might predict early progression. It seems like some of the clones that might eventually result in transformation are present at such a low level at diagnosis that they're not easy to find. There are more and more data coming out about transformation, and these are a few interesting studies. First of all, top left corner, you see that patients who are diagnosed with follicular lymphoma and transformed follicular lymphoma at the same time have a survival that's roughly equivalent, whereas those that develop transformation later on, the green curve, unfortunately don't live as long. On the top right, actually, are people who have known or suspected transformation, those two curves. In other words, when we suspect that transformation is likely, even if we are unable to biopsy it and prove that it's there, in fact, it likely is there, and we should treat them as though they're transformed. On the bottom right, we see the survival of patients with transformed follicular lymphoma relative to large cell lymphoma, and they're quite similar. And then on the bottom left, you can see that these are essentially the best data we have for the survival of patients who experience transformation later on. This is the likelihood of their survival from the time of transformation in the yellow curve. So it averages about 3 to 5 years. I remember when I was a fellow, we used to always say it was 1 to 2 years. It's better than that now. So quick summary, follicular lymphoma is a disease of excess morbidity. Roughly 20% of patients experience early events, and 30 to 50% of these events are early progressors. Early progressors are likely related to histological transformation. So how do we manage these people? I think a lot of us consider autologous stem cell transplantation as a reasonable option, and there are not a ton of data looking at autologous stem cell transplantation in early progressors, but this is data that Carla Casula put together from a CIBMTR registry looking at patients with early progression specifically who underwent a stem cell transplant, and then also comparing them to a group of patients who did not undergo stem cell transplantation. And you can see that those who underwent stem cell transplantation appeared to do better. Obviously, when we're looking at retrospective data, there are some biases there. In particular, it seemed like those who did better were those that underwent stem cell transplant very near to the time of early progression within the first year. Sony Smith, who was here earlier, I don't know if she's still here. It's always kind of weird to present somebody else's data to them, but sometimes helpful to answer questions. So she looked at similar data set from the CIBMTR and looked at both at autologous stem cell transplant and patients who underwent allogeneic stem cell transplantation. And you can see on the top right side, there's the risk of relapse. And in particular, what you see is, first of all, relapses start to plateau after about 4 years. In other words, some people that are early progressors who undergo autologous stem cell transplantation can have quite durable relapse-free intervals, but that initial period of time, unfortunately, relapses are still quite common. Seem to get fewer relapses if we use an allogeneic stem cell transplant, but of course the non-relapse mortality is significantly higher, and so overall survival ends up being quite similar. So we don't have a real answer of which of these is the best option. I've always sort of wondered, is it possible that an autologous stem cell transplant could change disease biology in these early relapsers and potentially protect against bad clones? And this is data from an Italian study looking at upfront stem cell transplant and first complete response. And essentially they show that there was a significant benefit in terms of progression-free survival, but no difference in overall survival. Presumably, some of those patients in that trial would have been early progressors, and it does not appear as though their survival was better because of the stem cell transplant. Maybe that's because there are limited numbers, but maybe the setting, maybe the stem cell transplant only saves lives if it's later in life. I suspect that it's probably true that it doesn't really change disease biology. It's just that when we use it in the second-line setting, it's more effective than less intensive therapy, the same way as it would be in the first-line setting. This is a current intergroup trial led by SWOG, and it looks specifically at patients that are experiencing early disease progression within the first 2 years of frontline immunochemotherapy. The trial was originally designed to look at patients who had progressed within 24 months after bendamustine and an anti-CD20 antibody. Since then, it's been amended to include CHOP and an anti-CD20 antibody. Those that received bendamustine are randomized to receive either CHOP obinutuzumab, TGR-1202, which is a PI3 kinase inhibitor plus obinutuzumab, or lenalidomide obinutuzumab. Those that receive CHOP in the frontline setting, same randomization except it's bendamustine. So let's discuss what's the rationale behind those treatment arms. So the reason for including obinutuzumab essentially comes from the Catalan trial. It's not exactly perfectly applicable to this patient population, but essentially, as Jonathan and Sony mentioned earlier today, obinutuzumab plus bendamustine was shown to be superior to bendamustine alone, both in terms of progression-free survival and overall survival. So there's a suggestion that patients who have some inherent resistance to rituximab may do better with obinutuzumab for whatever reason. So there's reason to include that in a trial like this. How about PI3 kinase? So it turns out PI3 kinase is a very good target in follicular lymphoma. We now have three agents, three PI3 kinase inhibitors that are approved for follicular lymphoma. Idelalisib, which was the first, copanlisib more recently, and duvelisib just a couple weeks ago. In the clinical trial, we're using the TG-1202, and there are other PI3 kinase inhibitors in development. You can see that they all target the delta isoform of PI3 kinase, and then there are some differences, including alpha in copanlisib and delta with duvelisib, or gamma with duvelisib. There are different delivery mechanisms. So copanlisib is unique in that it's intravenous weekly. You can see that so all of these trials were done in patients who had received an alkylator and rituximab. All patients were essentially relapsed on both of these drugs. The idelalisib trial required that they were refractory to both of them. But most patients in all of these trials were in fact refractory to their last prior therapy. You can see that they all have similar response rates and similar complete response rates. and they all have similar progression-free survival. There are some differences in the rates of toxicity. I think a word of caveat in interpreting those differences are that some of the toxicities that we've seen with idelalisib were toxicities that became more prevalent the longer follow-up we had. So in particular, colitis and pneumonitis were things that were not immediately apparent in the first phase 1 or phase 2 trials, but as we followed patients for longer, as they were on the drugs for longer, we started to see a little bit more. Similarly, sepsis and opportunistic infections only became clear when we started to combine idelalisib with rituximab, bendamustine, rituximab, and in earlier lines of therapy, like in the frontline or second line setting. So whether the other PI3 kinase inhibitors would have similar toxicity profiles or not is hard to say, but I wouldn't be surprised if they're more similar than they are different in that sense. Some people think that the alpha inhibition or this CK1e epsilon inhibition in copanlisib and TG1202 might protect from those adverse events, or differences in pharmacokinetics, for example, copanlisib being dosed weekly. And with the Insight drug, patients are switched after 9 weeks of therapy from daily therapy to weekly therapy, and that could also theoretically protect from some of these adverse events. The one key I will mention with copanlisib, which was one of the questions here, is that alpha inhibition in copanlisib is associated with hyperglycemia, which peaks at about 4 hours after the infusion of copanlisib. So if you choose to administer copanlisib in your patient, one key is to make sure that glucose is very well controlled prior to dosing copanlisib. The other key is to not overreact. The glucose will peak at about 4 hours and then it will go down. We're more likely to cause problems by over-treating hyperglycemia with a lot of insulin, and then the next morning somebody is profoundly hypoglycemic. So control it beforehand and then it will be okay. There are data from copanlisib, or from idelalisib rather. So the initial trial included multiple indolent non-Hodgkin's lymphomas. There was a publication from Ajay Gopal that looked at the subset with people with follicular lymphoma, and then an even more subsetted population who had experienced early progression in that original clinical trial. And you can see the response rates and progression-free survival were essentially the same in all of those subgroups. I think that we're likely also to see that that's probably similar when other PI3 kinase inhibitors or other drugs look at that, we're likely to see similar effects. But a note about looking at these unplanned subset analyses. The patients that were enrolled, for example, in that idelalisib trial were not all early progressors. A small subset of them were. They had of the early progressors, they had a median of 3 prior therapies. That means that an early progressor had to live long enough to get another 2 therapies before they ultimately were included in this clinical trial on average. So you can imagine a scenario where somebody experiences early progression with follicular lymphoma, doesn't get many subsequent therapies because they're too sick or whatever else, is not ultimately eligible for a clinical trial, and maybe doesn't have this kind of response to a PI3 kinase inhibitor. And so if you cut, for example, that curve after the first year, which is on average the time it takes from somebody to have early progression to the time they're included in one of these clinical trials, and you take those patients specifically, you can see that they do a little bit better than you would expect. And so just take a little bit of a caveat when we interpret those kinds of data. So PI3 kinase inhibitors are among the most active single agents, but I think it can be debated how different they all are. I think that they all require different kinds of monitoring, and so patients and providers have to get used to that. The other thing I think is unclear are different kinds of combinations may result in different kinds of toxicities. We've seen that with idelalisib and bendamustine or rituximab. We also learned in the alliance that combining idelalisib with lenalidomide was not a good idea. So it will take a little bit more work to figure out how best to use these agents. Lenalidomide is the third arm of that clinical trial. This is data that was presented by John Leonard a few years ago. And essentially, in this clinical trial, patients with previously treated follicular lymphoma received lenalidomide or lenalidomide plus rituximab. The addition of rituximab to lenalidomide clearly improved the response rate and overall response rate, as well as progression-free survival quite significantly. It essentially doubled progression-free survival. It's clear from looking at the adverse events that the majority of adverse events in this trial were related to lenalidomide, not rituximab, at least grade 3-4 adverse events. The augment trial is a similar concept, a little bit reversed. In fact, in this trial, patients with previously treated follicular lymphoma, these were not patients who were double refractory, right? These were patients who were eligible to theoretically receive single-agent rituximab, and they were randomized between single-agent rituximab or the combination of lenalidomide plus rituximab. This trial, there was recently a press release suggesting that the trial had met its primary endpoint. In the press release, they hint at a trend even towards improvement in overall survival, and we're likely to see this data presented in the near future. The magnified trial is sort of a similar design where everybody with relapsed or refractory indolent non-Hodgkin lymphoma receive lenalidomide plus rituximab, and then they're essentially randomized to further lenalidomide rituximab or just rituximab maintenance. In an initial look at some of this data that was presented fairly recently, we can see that they subdivided, again, same caveats apply here, they subdivided patients based on double refractory status or early relapsing status, and at about 1 year, about 70% of patients, whether they were double refractory or early relapsing, were free from progression. There is emerging data with obinutuzumab plus lenalidomide. I won't spend a lot of time on it other than to suggest that the combination appears safe and active, and so it's reasonable that it would be included in the SWOG trial. So in conclusion, early relapsing follicular lymphoma, I think, is really a key unmet need in follicular lymphoma because these patients experience excess mortality unlike most patients with follicular lymphoma. The best strategy for these patients remains unclear. I think novel anti-CD20 antibodies, PI3 kinase inhibitors, and immunomodulatory drugs have activity in the patient population. But the optimal selection of these drugs depends on patient selection, combinations, and sequencing. All of that, I think, is still a little bit unclear. So I put here sort of my approach, and you'll see that I really don't have a great approach to this, unfortunately. For known or suspected transformation, if patients have received a prior anthracycline, suggests some other standard second-line chemotherapy regimen like RICE or DHAP. If they are candidates for stem cell transplant, I would consider that. If they're not candidates for a stem cell transplant, some people have suggested lenalidomide maintenance. I don't think that's wrong. I'm not sure that it's necessarily right either. I don't know. If they have not received a prior anthracycline, then R-CHOP would be a reasonable option. Or we're learning that some of these patients, when they transform, have double hit lymphomas, and I think under those circumstances we would treat them with R-EPOCH. Historically, we've treated these people with autologous stem cell transplant, and that's probably still a reasonable thing to do. For patients that haven't experienced transformation, I list all of the regimens that are in the SWOG trial. I think that they're all reasonable, but I think there are nuances that might drive us to choose one or another. And then questions are, if somebody has a good response to a PI3 kinase inhibitor, for example, should that patient undergo an autologous stem cell transplant? Likewise with an lenalidomide-based regimen. We don't know the answer to that. The SWOG trial will allow patients to undergo stem cell transplantation. So I'd certainly encourage you to consider participation in the SWOG trial because I think it is a fairly important question, and it's only 45 patients per arm, so it's something that we should be able to answer. Thank you very much.